Hi, everybody. So I'm sure if you saw a video last week, it was actually quite an old one, and it had someone just slipped through the cracks, and I never posted it, I think, to the group. And well, at least I can't find it when I'm going back. So I was a lot thinner back then. It's motivated me to get back to the gym uh, when I look at myself now. So, we had actually recorded the second part, but the audio was terrible. So I think that's why we never ended up sharing both of these. So, toxinology and snake bites quite important. And we got quite far where we discussed all the different types. And what I'm going to do is after this, I'm actually going to um, also do one on scorpion stings and spider bites as well, so that hopefully we'll have like a complete breakdown of this and you guys can watch it. Yeah, let's get into it. So the last that we had covered, uh, let me just get there. So we had gotten up to basically all of the different types and how you classify all of them and when you should be worried and when you shouldn't be worried. And now we get into the management, which is a separate thing all on its own. So these are some of the myths regarding management of snake bites. So the first is that sucking out the venom helps. Now, the thing is, when the venom is injected, it's generally injected intramuscularly into the adipose or directly IV sometimes. It just depends on where you get bitten exactly. So its spread is actually quite quick and it's quite impossible to actually suck out the venom. Number one, you'd have to have quite a large amount of force to actually be able to remove the amount of venom that normally comes out. Number two, sucking it out wouldn't help because the spread occurs very quickly. Then the other one is incising of the wounds, which is also a similar sort of thing that if you cut up the wound, you create more space for the venom to actually leak out. The truth is that you actually only create a place for bacteria to go in. So you actually make the wound much worse. So try and avoid that as well. Amputating digits, it prevents spread. I mean, legacy, most of these myths, and they're long held myths, came about at a time when people didn't have an understanding of the vascular system and how these venoms actually spread and the rapidness with which they spread. So they felt that if you got bitten on the toe, cut off the toe. You got bitten on the finger, cut off the finger, and that would immediately stop it. But the truth is that the venom spreads quite quickly, even though its effects may take a little while to actually show, but it spread quite quickly. So, and these are some of the things that come across in the literature. So people have talked about application of petrol, ice packs, potassium permanganate, snake stones, and electric shocks. Now, it's not to say that these things have no place in medicine. I mean, the application of ice packs is well known to bring down swelling. Potassium permanganate, I know, has been used in some wound care, but not to great extent. Petrol, I don't see the use of it because it's a highly volatile hydrocarbon. It's not really going to do much. Electric shocks, again, are affecting the musculature and the nerves. They're not actually getting to the bloodstream, so it doesn't make much sense to actually do this. Now, snake stones are more of a traditional belief, and it's not isolated to South Africa. This is found across Southeast Asia. This is found in Australia. Well, not specific snake stones, but specific things that could be done. Now, the one myth we talk about that actually, or let's say not myth, but tradition that actually works, I'll speak about a little bit later. And I did have the chance to speak actually, we had I can't remember when it was. I think it was about 2 or 3 years ago. One of you actually phoned me and we had actually discussed the use of this technique. But anyway, we'll talk about that. Now, tourniquets are not generally used except for black mamba bites. Now, the reason why it's used for black mamba bites is that it can actually slow down the spread of the venom. Yes, it can. There is no doubt. But it's not generally used, and just due to the severity of the neurotoxicity from the black mamba. So some people have suggested, but there's conflicting reports on that as well. So I would say from a medico-legal point of view, and if you have to really look into it, I wouldn't actually do it. So yeah, I would stay away from doing tourniquets at all. The chances are you're going to cause more harm than good, especially if you've got a cytotoxic variant, because all you're doing is actually increasing the what you call it, the anaerobic destruction of cells as well, which is also going to contribute to the cytotoxicity and can actually mask the severity. Okay, so those are some of them. Now, what do you do? Okay, so those are the myths. So you're not going to suck the venom out. You're not going to cut the patient. You're not going to put snake stones on it. So what are you going to do? So first thing you do is remove constricting clothing. Now that might sound counterintuitive, but there's a lot of wisdom behind this actually. Remember, you can't actually stop unless you stop blood flow completely. So what you're actually doing, especially for a neurotoxic patient, is that you're decreasing the amount of constriction around the thorax. So that's the main thinking behind it. So it allows the patient to breathe a bit more freely. And then, of course, you want to reassure the victim. Now, the reason for reassurance and trying to calm the person down actually has to do with, your release of your adrenaline and things like that. You want your patient to have as low a heart rate as possible. I mean, be calm. Otherwise, you're going to spread the venom, of course, a lot faster. You need to arrange urgent transport. Immobilize the patient again, because the more muscle movement, the more your heart has to pump, the quicker the venom gets circulated as well. And you want to take we say dead snake. We hope, you can kill the snake, but if not, at least a picture of it, a description of it, and things like that. Now, this is if you are in the field, which a lot of us may be. You may be confronted with this sometimes where you are in the field, at a family gathering, at a sport event. This is what you would need to do if that occurs. Okay. So your patient is transported now. Your patients come to your emergency department. What do you do? And it's actually very simple from the emergency department point of view in majority of the cases. So you do your CABs, your basic, your absolute basics. You just keep your patient alive. If your patient's heart rate starts to dip, if their breathing capacity is decreased, you just need to keep them alive as much as possible. Analgesia, we try and stick to paracetamol or paracetamol and codeine. And if you're lucky enough to work in private, you'll have IV access to, you'll have IV paracetamol. We do have it in the state in South Africa as well, but it's much more difficult to obtain. They normally have small reserves of that. It's normally reserved for ICU, so you have to make a special request for it. I know in our case, you try to avoid aspirin and NSAIDs for the simple reason of coagulation. So especially if you're not sure which you are dealing with, like you wouldn't know for sure if you're dealing with a hemotoxic boomslang at first, so you try and avoid those. But once you know that it's not the case, you can move on and give NSAIDs if needed. And you avoid opiates if there's respiratory depression, simply because it will aggravate it. And remember your fluids as well. Now, this is more especially true in your cytotoxic patients, especially those who may already have tissue breakdown, and you treat them like a burns patient, But remember what we had discussed in the previous one is that they're quite prone to hyponatremia. So you've got to keep an eye on that. And of course, they can become hypovolemic as well. So these are just a few of the things that you need to worry about in the emergency department when the patient initially arrives. Okay, now let's get on to the main topic for today, which is anti-venom. Now, in South Africa, anti-venom has been quite strangely moved to all of the central hospitals. So, for example, like we're at Maditeni in KwaZulu-Natal, we used to have quite a good stock of anti-venom actually, and that anti-venom's now all been taken away to our tertiary center, our central hospital, which are Graves Hospital and Albert Lutuli Hospital. And that's occurred, I know, in Gauteng as well. And it's quite strange because you actually want to try and give anti-venom as quickly as possible. So I can't say I agree with it. I'm sure there must have been some thinking behind it. I know they did have one or two adverse events with patients, and so that might be the thinking behind it. But the truth be told, you need to be able to administer it as quickly as possible. So there's two types that you get. So the first one is called polyvalent. Right? So polyvalent simply means that it's effective against different types of venom. Okay, so it's effective in all, it's used in all envenomations. All right. Now, an envenomation is not a bite. So a lot of patients get bitten. A lot of people get bitten. But about 50%, you remember I said 50% of bites are dry bites. That means there's no venom that's actually put in. It's just a warning shot by the snake to say, listen, stay away from me, otherwise I'm going to give you more trouble. If you don't, or if you're close to a nest or something like that, then you might definitely get an envenomation. So when do you use polyvalent? In all of them, except these three. So the three are the worm slung, in our case. Now I'm talking about the South African context. Worm slung, berg adder, and vine snake. Now it's going to be difficult to remember these. So I call them the nature snakes, all right? Because for those of you who speak Afrikaans, berg, mountain, all right, boom, tree, and of course vine is vine, So that's the easiest way that I remember it, and I've remembered it all these years, is mountain snake, berg adder, worm slung, tree snake, and the vine snake as well. So those are the only three where you don't actually use your polyvalent antivenom. And then for worm slung, they actually use, so remember worm slung is a hemotoxic, which we had discussed previously, and they have monovalent antivenom because it's only effective against worm slung venom. So basically, if you get bitten by a vine snake or berg adder, you're going to die. No, that's not the case. Basically, there is no anti-venom in our case. Now, if you were to expand this and you were, for example, to go to Australia, you were to go to India, you were to go to the States, where you have these large numbers of venomous snakes. Now, South America also has a large number of snakes, but they tend to be more of the constrictor type, So your pythons, your boa constrictors, your anacondas, who don't actually rely on venom, they rely on constriction. And this is also true in India. India has a lot of cobras as well. Australia, we know, has so many. I think it was the golden snake, and there's so many. All the really venomous ones are there in Australia. So I can't speak to their context because it doesn't really affect us to that extent. So this is purely in the South African context where we have worm slungs, and the others. So in our context, and I think this is also true of the rattlesnake in America, because the rattlesnake is also a hemotoxic, a snake that also produces quite severe coagulopathies and things like that. And they tend to have monovalent antivenoms. Now, it depends on where you work. What I would suggest is that look up the local fauna, look up the local species that are available to you if you are working somewhere else, and see what's available. Do they use polyvalent? Do they use monovalent? Because those are the only two that you get. Now, in a lot of cases, they will have monovalent only available. Sometimes they have polyvalent. It just depends. Now, if you do get bitten in South Africa by a vine snake or a berg adder, you are going to get sick. We cannot treat you with antivenom. However, we will put you in ICU and we will control your symptoms until such a time as the venom is no longer taking, has no longer taken effect. So this is one of the reasons I hate going to the Drakensberg, because if you do get bitten, you're in a lot of trouble from the berg adder. The vine snake, okay, now it's still venomous, but at least it's a bit easier to manage. But berg adder bites are not something to be sneezed at, that's for sure. Okay, so just remember the two types, monovalent and polyvalent. Okay, so what does antivenom do? So antivenom is derived from snakes, So what happens is that we take the proteins that are found in the venom and we basically synthesized a counter to those, So proteins that would block the receptor sites and thereby decrease the effects of the venom. Okay, so antivenom neutralizes a fixed amount of venom. That's it. That's all that it does. It neutralizes the amount of antivenom you give, will generally neutralize a specific amount of venom. And when a snake bites, it doesn't discriminate between an adult and a child. So the amount of venom that's injected into adults and children is the same. So the dosage of antivenom is the same. It's one of those rare cases, and unfortunately, it applies even to very young kids as well. And it can get quite difficult with a pediatric patient because you have to temper the amount of antivenom you're giving with the risk of side effects, and how do you manage those side effects as well. So it can get very, very tricky at times. But luckily, it's not something most of you'll have to face unless you're in a highly endemic area that deals with multiple snake bites on a regular basis. So is antivenom needed for all bites? No. It's not needed for all bites. So 10 to 50% of bites from venomous snakes are dry. So they do not cause, basically the snake does not inject venom into the victim. Now, this doesn't mean that if you don't see immediate effects of any venom, you assume it's a dry bite. Patients should be kept for observation. Patients should be monitored for a total of at least 24 hours. And if they're showing no signs of any adverse effects, then definitely you know it was a drive-by. The patient can be released and discharged. But I would suggest keeping all bite victims at least for 24 hours for observation. And what happens is, especially with the cytotoxics, depending on the amount of venom and the area at which the bite occurs, gravitational forces, things like that, it can take a little bit of time, although not that long. But you normally see effects quite quickly. So don't just immediately throw in antivenom. So when should you give antivenom? So these are the indications for antivenom. There's obvious neurotoxicity. Your patient is GCS is slowly going down. Their breathing is becoming more shallow. They're showing signs of cardiotoxicity as well. So bradycardias, arrhythmias, flaccidity. Sometimes they do get a more type of a rigid paralysis, but it's not common in South Africa. But I know in some of the other snakes do cause a more of a rigid paralysis. If there's signs of coagulopathy, so what are the signs of coagulopathy? Oozing at the wound, bleeding gums, bleeding wounds. You'll try and take blood and you just can't stop the bleeding from the vein, things like that. And then rapid and extensive cytotoxicity, so at least half the limb. So most of the bites will occur on the extremities, so the feet, the hands, sometimes up to the calves. It's very rare to have it in other areas, but it can happen. And with most cytotoxic envenomations, what will happen is that you get this rapid breakdown of tissue that happens, and it should cover at least half the limb. But in all honesty, if it is proceeding very rapidly, we have used it on patients much quicker than waiting for half the limb to be affected, simply because that amount of tissue breakdown also has its own problems. You're now releasing a lot of, you're losing a lot of tissue, you're losing a lot of fluid, you're introducing a lot of anaerobic byproducts into the circulation, so you're creating a lot of problems. And then, of course, like I said, the cardiovascular manifestations, so arrhythmias, shock hypotension, things like that. So if a patient looks sick and really, really sick, then you've got to start giving your antivenom. So the problem is a cure can be as deadly as the disease. Antivenom can lead to extreme anaphylactic reactions. That's the problem. And it's not something to be taken lightly. So you shouldn't administer this unless you have somebody standing next to you who is a senior, right? So I would suggest a specialist physician. If you have nobody else, at least a surgeon, an emergency medicine physician, or at worst comes to us, telephonic guidance from poison control. So poison control, in our case, Afritox in South Africa, they're extremely good. If you're not sure, you forget everything that I've taught you in these lessons, you just phone them up. They'll tell you exactly what to do, how to do it. They'll guide you step by step. They'll even call you back on your cell phone and take you through what needs to be done. So it requires prophylactic adrenaline, continuous monitoring, which I'll get into just now. Now, remember, it's never too late to give antivenom. Now, of course, if your patient has demised, yes, that's too late. I'm not trying to light of the situation, but I mean, until that point, you can still give antivenom, but the earlier you give it, the better. Hence my apprehension of them removing it from most of the district and regional hospitals. Okay. So what do you do before you give it? In other words, how do you set it up? Now, what we normally do is that we give our patient at least one dose of a hydrocort, or heavier steroid if available, at least 200 milligrams in adults, for example, of hydrocortisone. I have even run a hydrocort infusion on these patients just to try and prevent the onset of severe anaphylaxis. However, this comes with a little caveat. Go according to your local protocols. This is just a little anecdotal side thing. It's not part of the protocols that are generally accepted, but I have done it and I haven't had any bad effects from it. And I also keep my patients on low dose adrenaline. So 1 m in 200 mils at 5 mils per hour. The reason why is that if things start going badly, you're already on the winning side. If your patient starts getting anaphylaxis, number one, you are giving low dose adrenaline. So the chances of that happening are decreased, but you're also increasing your chances that you'll be able to start an inotropic infusion, a heavier adrenaline infusion. And truth be told, adrenaline IV should never be used for anaphylaxis generally. You should use it IMI. There's a lot of intricacies in using it. So using doing it in this way presents not much danger to the patient, and will allow you time to actually assess, get advice, and go forward. So these are the two things that I normally do. But even if it's given, hydrocort is given as a single dose IVI, you don't start the low dose adrenaline, it's not really much of a problem, but you need to be ready. So yeah, I wouldn't rush into giving antivenom without making 100% sure of your local protocols. So in our case, we do have our protocols ready in our emergency department, and if you go into the protocols on the website, you'll be able to find it there. It's called toxicology and toxinology protocols, and you can see what we've written over there. Okay. So I normally add an antihistamine as well. And then, of course, you keep the adrenaline, antihistamine, also nebules for nebulization, and hydrocort at the ready. Have everything there in case things do go badly, all right? But basically, you make sure a senior person is next to you. Don't do this on your own unless you really, really are stuck. And even then, a senior person can simply be poison control on the line. Don't go it alone. Patients can change condition very quickly. Patients can need very, very advanced life-saving maneuvers in order to treat them. You need advice. It's a difficult situation. It's a situation in which it's easy to panic and easy to lose control. And the best thing is to have somebody with experience there with you, be it in spirit. When I say in spirit, I mean on the phone, or physically next to you, so that you can make the right decisions and save that patient. Now, it doesn't matter where you work. That's a basic tenet of treating these snake bites. Okay, until you've had some experience in treating them, don't just rush ahead and go into it. Okay, so how do you give antivenom? So it's administered IV, simple peripheral line. You don't need anything special. So especially for our polyvalent ones, we take 5 to 10 ampoules, which is 50 to 100 ml, in 200 ml of normal saline, and it's infused over 30 to 60 minutes. Now, if you've set everything up, this is the type of thing that you can quickly Google or Bing or whatever you want to use, and you can easily work it out. It's not really a problem. And remember, it's the same for kids and adults. All right. Now, black mambas, on the other hand, may require as much as 20 ampoules. I've seen in some of the literature where they've gone even above that, but those are quite exceptional circumstances, but they have used that as well. And then a boomslang antivenom is a standard 20 ml dose. So it comes as a standard vial. You just put that in the 200 ml and you pass it through. And the patient may need multiple follow-up doses, actually, but generally that's not done in the emergency department. It's done in ICU or in the relevant treatment area. Okay. So what happens now after you give your antivenom? Your patient won't get better. Quite surprising. It's not like it is in the movies where they just give them the antivenom. The patient wakes up like, where am I? What happened? You were bitten by a snake. Oh my God, how am I like? It's nothing like that, actually. All that it does is neutralizes that venom that hasn't actually had a chance to hit the receptors yet. So what it does is it blocks any further attempts by the venom to produce its effects. But it doesn't actually reverse those receptors that have already been locked onto. Okay, so I hope that makes sense. So in neurotoxic venomations especially, there's really not much of a change. Now, in the hemotoxic, you start seeing a decrease in the coagulopathy. You do start seeing that, there is no doubt. And in the cytotoxic, there's not much difference because you've already got damage. It's just that it limits it limits that. So like I say here, the coagulopathy from the boomslang, it reverses quite rapidly, and you do see it coming down. But these patients sometimes do need follow-up dose, especially if it's a high-dose envenomation, all right? And your patients will need ICU ventilator support with the neurotoxic envenomation, because it does take, and from experience, I can tell you, normally it takes quite a few doses to actually get it under control. So you give it. You still need to intubate the patient if necessary. You still need to try and, try and treat their fluid loss and whatever bleeding that they've got and things like that. But at least with the Bond-Slung monovalent, it does reverse relatively rapidly. Even if a patient is still oozing, but it won't be to the same extent. If they are bleeding, it will start to slow down. And normally after a second dose or a third dose, although I haven't read much of a third dose, but I know in the second doses, it normally does settle down completely. So this is the main thing. Patients may and very often do develop anti-venom reactions, so it's a severe anaphylactoid reaction, and it really is severe. It's akin to somebody who's allergic to bees getting stung by a bee, and a severe penicillin reaction. It's exactly like that. Everything just swells up. The airway can be compromised. They be going to anaphylactic shock. There's a whole lot of things that happen, and that's why it's important to have that hydrocort, antihistamines, and adrenaline already running. Now, if you haven't for some reason, then of course you give your IM adrenaline, IV antihistamines and steroids. But if you followed what I said before, you shouldn't have to reach this stage, But you'll manage it like any other anaphylaxis. It's not any different to that. You're basically trying to reverse the anaphylaxis. So this I just want to talk about is snake venom ophthalmia. So this is when venom is spat into the eye. Now, in our case, we have the Mozambican spitting cobra, which is more common in northern Natal, so going out towards Impangeni and Richards Bay and areas like that. And we've had a few cases over the years. And what do you do when that happens? So the thing is, you irrigate with large amounts of fluid. Topical anesthetics allow you to open the eye. There's no anti-venom for this because there's no systemic spread. The damage is directly to the cornea and directly to the sclera. So it causes quite a rapid, disconnection of these areas, and that's where the problem comes about. Now, even in saying that, they only require review by an ophthalmologist. It's not an emergency management by the ophthalmologist. You normally just irrigate it with large amounts of fluid. And I was talking earlier about a tradition that people use. So in certain areas, there is, especially those who are in northern Natal, there was the tradition of passing breast milk over the eye. Now, it may sound very silly initially, but there is actually quite a good bit of science now that backs that up. And I remember somebody phoning me about 2 or 3 years ago with a similar problem, and they were irrigating but not having much. And I actually advised them, go to the maternity ward, get some breast milk and pass it into the eye. The reason being the high fat content. So the high fat content works exactly as you think it would. It chelates all of this venom. It basically catches it in micelles and it flushes it out of the eye very quickly. Now, if somebody who's been bitten, please do not put breast milk into the wounds. But this is specific for snake venom ophthalmia. Now, of course, it's something that can be done in the field rather. And if you are struggling with irrigation and you can see there's extensive discoloration of the eye, you could try it as well. I'm not saying please, as soon as somebody comes in with snake venom ophthalmia, go and find somebody who's breastfeeding and steal some of their milk. No. But it's just amazing to see that it's a tradition that had started and was used, and there is science to actually back it up. So as much as science has disproved a lot of the other myths, this is one, or a lot of other traditions, let's say, this is one tradition where we can actually say, okay, you know what, there is science to back it up. So these are just some graphs just to show you in South Africa the spread. So we can see the puff adder. So it's basically everywhere. And then the Gaboon adder, all right, the Gaboon viper, and these are the areas where they are more. So the stripe means both of them. But as you can see, the puff adder is quite widespread across Africa. And here we have the others. So the Mozambican spitting cobra, as I say, for those of us in Newcastle, we're just about there. So, it's quite, common for us. The black neck spitting cobra, not seen except on the west coast of South Africa here, as well as the barred spitting cobra, the black spitting cobra. So at least those of us who are in KwaZulu-Natal, we don't see it much. Those of you who are in the Western Cape, Namibia, going up, you may see that a lot more. And in specifically in our situation in Newcastle, we have a lot of wrinkles. So wrinkles are the cobra that causes severe cytotoxicity. So we tend to overlap, but in Newcastle specifically, we have a large population of the wrinkles cobra, and we tend to see more of those cytotoxicity cytotoxic bites. These are just some of the others. So the green mamba and the black mamba. So you can see Natal is quite unfortunate to have those. Although I must be honest, it's seen more in towards Durban and that part of the coast. But they are present throughout KwaZulu-Natal as well. And this is our boom slang or tree snake, which you can see is present in quite a few areas. Not in the very mountainous areas. And then the vine snake or bird snake, which luckily doesn't come too close to us in Newcastle. We're just on the border there, but they are there. So these snakes now are not as common in the urban areas, but more common in the rural, in our outlying areas. I'm not talking about, when I say rural, what I mean is undeveloped, wild areas, where you go for hiking and camping and things like that, so that's generally where you find those. So that's just a bit of geography as well. And that's just a little joke just to finish off. So hopefully we'll do one again now about scorpions and spiders, just to give you all some insight into those as well. And God help you if you do have one of these patients. It's a very frightening thing because there's a lot of emotion attached to it as well, in terms of family members that may be accompanying and things like that. There's so much of a societal and cultural fear that's bred in around snakes, and tradition that's bred in around snakes and their bites, and you have to deal with that along with treating a patient. And I remember facing a situation where somebody was insisting that they want to come in and douse the patient in petrol and things like that. We had to physically restrain the person and take them out, because you're trying to explain to them, it doesn't really work. No, we used it for somebody else. And it's hard in that situation to explain to somebody like, no, the person that you used it on likely had a dry bite. This person's got envenomation. So, it's not an easy thing to do. And to be then honest, I would actually say the dry bites are a bit higher than what the statistics, from my experience. I would say the majority of them, maybe up to 70% of the bites that I've seen, have been dry bites. But the 30% that haven't been, it's not been fun. Let's put it that way. It's not been fun. And the good part is, once you get the basics done in the emergency department and the patient goes away to, well, in our case, Gray's Hospital and the Central Hospital, and they have specialized units that deal with this, the survival rates are actually quite good, surprisingly. It just depends on the length of time from bite to treatment. And of course, as that progresses and as more and more receptors are affected, especially in the neurotoxics and in all of them, actually, the worse the outcomes are. The quicker the better. The quicker the treatment is started, the better. Anyway, I hope you guys enjoyed that, and hopefully we'll carry on with it next week again, and we'll have our little series. Okay, keep well. Bye.